Oh, Kevin, I think your mute is on.
I'm muted. Classic start to a presentation. Um, so hi everybody. I'm gonna blow through a bunch of stuff. I attended a lot of different sessions at the conference, and so I'm gonna try to get through a bunch of stuff today. Um, so starting with like tips on working with OCD. People are new here to working with OCD. I know I didn't have a lot of experience before coming here. So some of the big takeaways that I got from like attending sessions with focus on like clinicians and how they could better work with people with OCD. Your treatment doesn't need to be perfect. You got to meet the person where they're at and not push them for what they're not ready for. Um, you're actually going to be probably on the same level as your client, where you might not feel ready to treat OCD, but that's okay. You actually have all the knowledge you need. You've got great support here and supervision, and you can provide evidence-based treatments to your clients, which are what they're looking for. Shame is something that is extremely difficult for individuals to face their own OCD. And so a big thing to focus in on is how you can help them to have more compassion for themselves, how they can feel more connected to other people, reduce that sense of shame and stigma, because that was like a prevailing theme throughout many of the stories of recovery that I heard. If you're looking for treatment guidelines, there's a link here from the people that put on the conference where they kind of point out that, yes, ERP is the gold standard of treatment, but it's not the only effective way to treat OCD. And if somebody's not ready for exposures, maybe you can take an ACT-based approach or ICBT-based approach, just depending on where the client's at. Attitudes that you might want to develop for yourself, recognize that there's not one right way to treat OCD, and there's no one right way to do exposures. Ultimately, all you really want them to do is have some practice. You don't need to be perfect to be effective. As a clinician either, you don't have to be perfect. You don't have to be as experienced. It's going to be like riding a bike where maybe it's going to be kind of a struggle to treat people with OCD at first, but recognize that just because you feel like you might not be ready doesn't mean that you actually are, in a very similar way that your clients might feel. So it's okay to acknowledge that you might be inexperienced while still trying to be confident that like you have the knowledge, you have the base skills, and you have the support to do this work. So don't judge your own competence on perfection. Focus more on the progress that you're trying to make with your clients. And also realize that like your client's readiness to do the work is going to matter a lot. This work can sometimes feel very slow, and you might feel like, oh my gosh, I'm not effective. I'm not making the changes that this person wants in their life. But that might speak more to their readiness and willingness. We all learn in school and are given these examples that are pristine and perfect, and this is exactly what treatment is supposed to look like. But that's not real life. Real life is not as clear-cut, and our work isn't as perfect. When you're working with people with OCD, be really aware of common comorbid disorders and try to look at what is driving the behaviors for people. Try to be curious and collaborate with them to understand why are they doing what they're doing, and let them guide you to understand what their internal experiences are, because they are the experts in that domain. Recognize that ERP is hard for everybody. It's hard for clinicians. It's especially hard for clients. If your client's not ready, maybe use an ACT-based approach. Let's focus on engagement and values instead, and trying to like reclaim your life from OCD. Start with exposures that are really small. Something that blew my mind was one treatment provider talking about reassurance. Yes, we don't want that for OCD, but if that's how you got to get started to get somebody to do exposures, that's fine. That's fine. We can meet people where they're at and start to build up their confidence from there, and continue to pull back reinforcement as things continue. Start with some wins. Look at value-based activation principles. Go for small positive actions that they can do. Don't just focus on what they feel like they can't do, or set them up for failure by assigning them to do something they're not ready for. You might want to increase their motivation by exploring the cost of OCD, figuring out what is taken away from their lives, and make treatment a focus on what they can regain in their lives. Normalize that progress is going to be slow and it's going to be nonlinear. They might take a step forward one week and 2 steps back another. They might refrain from engaging in a response, but then get into a compulsion another day. That's okay. Progress isn't perfect. We really just want to recognize that anything that they are able to do, that's practice, and that is a step forward. That's important. Be sure you use the Y box and Psi box, not only to have some kind of objective markers for success, but it also is so helpful for clients to understand OCD, where you can start helping them recognize what is an obsession and what is a compulsion. It can help them to be aware that, oh, I didn't even realize that I was engaging in these mental compulsions, that each time I had a thought that my loved one was going to be harmed, I would say this prayer like 5 times in my head. I thought it was just my religion. Is this maybe a sort of OCD? We also want to look at family accommodation. That's so important, and I'll get more into it later. But here's a link to the family accommodation scale so you can better understand what the family might be doing to accommodate the OCD behaviors as well. And then if you find wording that might be heteronormative, try to be sensitive in how you're asking questions or reframe it. This is especially related to like some of the topics of sexuality, where it's definitely heteronormative forward. You want to help them understand that OCD doesn't just affect them, it also affects their family. And we want to teach both the client and their families, the systems that they're involved in, that accommodation reinforces OCD, even when it feels like I'm supporting the person with OCD. So I've got this cycle of avoidance from Aureen Wagner in the bottom. And this is a great tool to kind of show your clients and their families that as we're kind of approaching the thing that makes us feel afraid, we're starting to complete the exposure. That anxiety is going up and up. And anytime we are accommodated or we avoid or escape completing the exposure, it starts this cycle where our anxiety gets reduced. We don't learn how to sit with the exposure, how to go through this. And so it reinforces the OCD. I feel like I have to do this again. This is the effective way to reduce my anxiety. Another analogy might be like the zoom in photo exercise. So you can take a photo or a piece of paper and show them how, if they were to bring this, if this was their OCD or their concerns, if you brought it all the way to your face, all you can see is your OCD, and this becomes your whole worldview. We want them to be able to kind of put it in their place, have this OCD and their fear, their anxiety be just a part of their life, but not the only thing they're focused on. It might be helpful to name what type of OCD the person has, just to increase their understanding and sense of community, that they're not the only ones with this. But also be careful with that, because trying to find a very specific label that is naming my exact experience could be a form of reassurance seeking in itself, and maybe a feature of OCD. So if that does come up, try to recognize that no matter what type of OCD you have, the treatment's going to be the same. We're going to figure out what is causing the distress, what OCD wants you to do, and we're going to have to figure out a way to expose ourselves to what makes us uncomfortable without doing the things that OCD wants us to do to get rid of our anxiety. And we can also look at it as like, this is practice of just having that good enough mentality. So overall, here's like a summary of working with OCD. One of the biggest things you're going to have to do is build rapport and relationship. This work is hard. Nobody wants to do something hard for somebody that they don't feel supported by and they don't like. So with that, no need to rush into ERP work. We want to make sure that the exposures we're trying to get the client to do, they consent to, and they have helped develop, that they want to do these things. We want to choose exposures that are based on their values, and we want to include their family or community supports wherever we can, because this can be really helpful. We also want to differentiate the difference between modifying a lifestyle so that they can do what's important with their life versus enabling them to avoid distress, but reinforcing their OCD. So maybe that would look like if somebody's skipping lunch because they don't have, because they have fears of contamination, maybe figuring out ways that they can have their lunch in a familiar setting and aren't just giving into the OCD. Not a great example. It is kind of a fine line, and that's something to really work on with your clients. When you're providing psychoeducation, which is extremely important when working with OCD or any disorder, we want them to understand what mental compulsions are. These are often overlooked, and we'll not necessarily treat this with exposure. These thoughts are going to pop up on their own, but more with the response prevention. What can we stop ourselves from doing mentally? Can we stop engaging in these mental rituals? We want them to understand that avoidance is a sort of compulsion, and it reduces our opportunities for exposure and habituating ourselves to discomfort. We want them to understand what causes OCD. Again, to take away that shame and stigma, let them understand that there are biological components where there's maybe overactivation or underactivation of certain neurotransmitters. Infections can lead to OCD emerging, and sometimes environmental things like traumas that we've experienced can lead to OCD. We want them to understand that this is an adaptive mechanism that's gone wrong, that OCD hijacks our brain safety system and overreacts to perceived dangers. So an analogy you might want to share is like a faulty alarm system, that like a smoke alarm. It's a smoke alarm is supposed to go off when there's a fire. And that's when it's working normally. There's an actual danger. But their OCD smoke alarm is more responsive to maybe like the heat being turned on in the house and thinking, oh, there's an increase in temperature. Oh, there's a fire. It's an overactive system. It's doing its job, but it's doing it too well. And we want to help it pull back to respond to real threats.
Kevin, can I stop you
Yes.
for a quick minute? Okay, so just going back to the psychoeducation piece, I'm just curious about, because we've talked about just doing a little bit more education on the brain, the neurotransmitters. You guys don't get a lot of that, and from like an anxiety, at least you got one from training, like an hour from the foundational training that you did when you first started on brain and the anxiety. So I'm just curious, a little bit of feedback from you guys when you're talking about causes. I've never heard it this way, of kind of definitely the adaptive mechanism gone wrong. I've heard that conversation, but do you all feel comfortable talking about kind of the causes or the biological information? Just show of hands. Does everyone feel okay? So most of you guys, okay, cool. Thank you. That was a selfish question, but just wanted to make sure everyone was comfortable with that. Thanks, Dr. Kevin.
Yeah,
You can begin.
Okay, let's go here. Okay, so when we're working with people with OCD, the qualities we want to exhibit as therapists, we want to really lean into the education. We want to be respectful. We want to honor like what is important to them, be empathic, collaborative. We need to be flexible, especially, and also really working to just motivate them. This is tough stuff. Aim for ERP. It's the gold standard. It's really effective. We want them to expose themselves to obsessions and refrain from engaging in those compulsive behaviors, but understand too, that's not the only way to treat OCD. When you are taking an ERP-based approach, we want to identify the themes of the obsessions, try to list out as much as we can the obsessions and compulsions. We want to do a behavioral analysis to understand what is going on here, what's triggering it, what is the function of these behaviors. Ideally, we'll create a hierarchy of different like feared or uncomfortable situations. And definitely we want to gradually assign increasingly difficult homework for the person to complete both in and outside of sessions. When things aren't working, we got to problem solve. We got to figure out how we could change this, how we could update it and make it better so that it will work for them. And to also use cognitive techniques. We want to help them refrain how they're thinking about exposures or how they think about themselves in the world. Remember that exposures can be both in person or they can be imaginal. We can just kind of run through things in our mind. And we want to treat both mental and physical compulsions as something that need to be focused on and are fairly similar in our treatment. Key concepts in treatment, we want to understand and make sure the client understands that habituation is key here, that our fears and anxieties will naturally reduce as we continue to face these stressors over and over again. We want to try to avoid as best we can reassurance, because that can just reinforce OCD behaviors. So with that, we want them to really know that like life is uncertain. OCD wants to know for sure and absolute certainty that the bad thing isn't going to happen. It might. That's just part of our lives. Perfection also, great idea, but it's not real. It doesn't exist. We're all fallible. Nothing is perfect, and that's okay. We want them to focus on control, being limited to just themselves. OCD is often about making sure that things don't happen in the outside world. We can't really do that. We can only focus on things that are in our control. And we also want them to know that it's okay to be uncomfortable, that we can actually tolerate this. This isn't the end of us. And that we can use alternative treatments if ERP is just not working at this time. Maybe it's ACT or ICBT or other cognitive therapy-based approach. Family involvement is super important. Unintentionally, family members often support and reinforce OCD either by reassurance seeking, aiding the person in completing their compulsive rituals, or helping them avoid stressors. So when there is family accommodation, treatment is less effective. There's also a high correlation with symptom severity, where the more accommodation provided, the more severe the symptoms. Probably vice versa also, the more severe the symptoms, the more accommodation there is. And while family accommodation is really common, we can change that. And here are some additional assessment tools and different kinds of family accommodation scales that we can use to kind of better understand what's going on. When we have a more family-based approach, the main goals are going to be reduce accommodation. We want to rebuild independence for the individual and normalize new routines. So this will often involve kind of like creating a sort of behavioral contract where we want to clearly identify where are we going to start withdrawing our accommodations for this individual. We want the expectations to be really clear. We want our support to be clearly defined so there's no surprises. This is just what's expected. You might work with the family on learning like Socratic questioning techniques instead of providing reassurance. You know, oh, it's really interesting that you asked, you know, if I had cancer. What do you think is making you ask that? Instead of saying, no, I don't have cancer. And we want the exposure to be gradual for both the patient and the family. We don't want to say, all right, family, stop doing all of your accommodations all at once. We want to slowly get into this and slowly pull back. At the same time, we're slowly pushing the client to do more. So other interventions that might be effective when working with clients would be definitely the psychoeducation. That's going to be huge. Space programs could be good for family. Reward systems and helping them develop like motivational scripts. We want them to help emphasize resilience for the client, let them know that what they're feeling is not permanent, that everything will pass. And as far as like tips go, we want them to really understand that avoidance reinforces OCD. When a family member is allowing their client to say, oh, I can't do this, and doing something for them, that's accommodating the OCD. We want to use a SUD scale to understand where their anxiety is starting to go down, but also so we can understand where anxiety stays the same and they're actually able to tolerate it and still go do the exposure, still go do what's important in their life. We have to be really flexible with our hierarchies. Rigidity and perfectionism sounds more like OCD. We don't want that. We want to be flexible and creating exposures that work for our clients. And maybe use your own insights. If you're really uncomfortable working with clients or you're struggling with them not doing the exposures, try to see that as being on the same page as them and use it to better empathize and connect with your client. As far as like tips for managing homework, patience, everyone goes at their own pace. Try not to take it personally. that they're not right away doing all the exposures and getting right back to where they want to be. Definitely don't assign homework that's harder than what they can handle. We want them to experience success. But at the same time, we can't just let them brush away not doing homework. We need to say, hey, but this stuff is important. How do we get you to go do these exposures or face your OCD? Be engaged in the treatment. If your client can't complete something entirely, oh, I couldn't do that. Okay, well, which parts could you do? Let's try to break it down further and see what we could start doing to try to get you to that larger goal. We want to reinforce partial efforts. We always want to be encouraging. This is really hard work. Oh, I couldn't do the exposure. I tried, I got out there, and then I turned away at the last second. Hey, you got all the way to the last second. That's awesome. How do we get you to push through that last step? Let's break that down, but I want to reinforce you even gave it an attempt. We want to set an expectation that we're always going to review what the exposures are. Maybe you make it an expectation that that's the start of the session, so that this is just the expectation. I think that can also be helpful. I've heard that from clients when they know, well, I know you were going to ask me about it, so I felt like that pressure outside a session that I had to do this stuff. Whenever we're creating exposures too, we want to be ethical. We want to make sure we never ask them to do something that we wouldn't do ourselves or we wouldn't be willing to do. Let them know that it's okay to fail. That's fine. We can always try this again. These opportunities to face these things are not leaving. But try to give it at least a week and a solid attempt before shifting gears and trying a different exposure. And when we're working with kids, maybe even adults, think about using rewards so that we can boost our motivation to do this work. When trying to make these exercises more effective for our clients, see if you can get them to set these exposures to occur at a specific time each day. Just build that habit, build that routine, use reminders, to do apps or reminders app, Post-its, phone, whatever, so that there is this external reminder, because maybe internally you don't want to do this stuff. Try not to allow procrastination. Encourage them to just have this do it now attitude. Also, we don't want the OCD to slip into the homework and compulsions. They don't need to be done perfectly. They don't need to be done in a specific way. The good enough mentality is going to be really important. Normalize regressions, that they might have done a great job of resisting their compulsions and then they started doing it again. Okay, that's part of this. Let's get back on your feet. Let's try to do this as quickly as possible to get back into resisting compulsions. If they don't feel ready, you want them to be able to express that to you. You want to have an open and honest relationship with them where they can tell you, no, I'm just not ready for this. Okay, what are you ready for? You want to stress independence, not seeking reassurance. Let them know that recovery is difficult, but at the same time, it's the easy stuff isn't going to get them where they want to be. So just try to be patient with them, but also encourage them to be patient with themselves. They'll have more than one opportunity to do these things. When working with families, we want to understand how families accommodate OCD. We want to try to include as many people as possible that are involved in the accommodation. Maybe it's doctors, teachers, other members of the family outside of the immediate family. We want to be mindful ourselves of what sort of accommodations we are providing our clients. They might do a lot of reassurance seeking and wanting you to tell them that it's okay, or this thing that they did was all right, that it fell in line with the treatment. And you might want to set some expectations on with them where you will and will not provide reassurance. You want to understand what drives the accommodation for family members. It might be the guilt and anxiety of a parent seeing their child in distress and they can't deal with that feeling. And so you might have to help a family member tolerate their own feelings of guilt or frustration or anxiety so that they can pull back on the accommodations. And we want families to understand that their participation in treatment is really important, that this is super effective for addressing OCD and improving symptoms. We want family members to model what it's like to complete an exposure and how to not provide reassurance. We may need to create some sort of like contracts and really formalized plans on what it's going to look like for family involvement with the individual with OCD. And we want to do this outside of the moment when OCD is really rearing its head. People are going to be emotional, reactive, not the time to make plans. We want to do this ahead of time so that we can go into this with a clear plan of action. We also want to pull back these accommodations slowly and gradually. And if things aren't working, as always, we can revisit them and change them. So when it comes to people with depression and OCD, we might take a more behavioral activated approach. We might shift our approach from jumping straight into ERP to recognize that people that have severe depression and also OCD are going to feel extremely low motivation, low energy, fatigue. They're not going to want to do this stuff. And so it might be more appropriate to focus on behavioral activation. Let's just try to do the things that you need or want the most. Explore medication as far as a way to boost those positive feelings and help them to be more active and engaged in their life. As we're doing these things, we want to collect data. We want to understand what is triggering these depressed feelings, how do they respond to it, how do they engage in this avoidance, and we want to figure out instead, like, what's going to bring them more balance in their lives. How can you engage in activities that bring you small, simple pleasures, like watching a show or having a favorite snack or treat or taking a nap or break, but also balancing that with value-oriented activities that are maybe a little more difficult. And we're not just leaning into all one or all of the other. We want to set realistic and gradual steps, kind of a theme for all of this. And we want to frame progress in a compassionate and reality-focused way rather than perfection. You know, you were spending all of last week in your bed. You got out of bed just to brush your teeth, take a shower, and then you went back to bed. That's awesome. Way to go. Like, that was really hard to do, and that's a step forward. And then we want to adapt whatever works for the individual, especially if they're just struggling to engage in anything at all. When we're working with like an ACT-based approach, we want to really focus on trying to increase their flexibility of mind. We want to help them learn to be focused on the present moment in a non-judgmental way of just being aware of their experience. So that's going to be helping them learn how to experience their feelings with a sense of curiosity and try to reduce their suffering by promoting an acceptance of pain rather than avoidance of it. Sounds very similar to our work with OCD, and this is that, right? This skill of being able to experience thoughts as simply thoughts. This is just an idea. If I feel worthless, that's just a thought, and we can then shift that into OCD when they're ready. I can notice the thoughts of, what if something bad happens? That's just a thought. That's not reality. I don't need to act on that. We want to promote the selfless context, the idea that I'm a container for my thoughts and feelings, but I'm not defined by them. There's so many things that contribute to who I am. There's my stressors at work or at home, my financial pressures, you know, how I'm feeling, the weather, my mood, my hunger. Like, these are all things that contribute to who I am, but I'm not defined by any singular thing. And we also really want to stress that acceptance doesn't mean that you have to like or believe your thoughts, your experiences, your feelings. You're just living with them the way they are. So you might want to explore their values. You can try to identify, if they're already aware of them, what the person's top personal values are. But there's also good tools. There's like the Bullseye worksheet from the Act Made Simple workbook that we all have. There's guided exercises to identify values. And we can try to see, okay, where is OCD starting to hijack these values? Where can we start to re-engage in these values so that you have control over your life and not OCD? And try to recognize that engagement in values is going to be flexible. It's not going to be a very rigid and highly structured thing. So when we're trying to help somebody with depression and OCD live with their values, we want to try to figure out, okay, how can you live with your values and better fulfill your roles where OCD might have taken that away? That I maybe not am eating with my family anymore because I'm afraid of being contaminated by them, and recognize, well, but this is a deep value. How can you still live out that value of being family focused and help them to make room for um, that discomfort that comes along with it, and refocusing on how this is something that they actually want. They actually want to try to engage with their values and do these things, because both OCD and depression attack our values. And when we re-engage with them, we're kind of completing an exposure to both of those issues. Um, we want goals to be really simple and achievable, especially for people stuck in depression. We want them to have those positive feelings that come from having a win, from setting a goal and achieving it. So starting really small and something that they can definitely achieve is going to be really important. As always, we want to be curious ourselves as to how it's going. So ideally, we can try to log these sort of exposures that they're doing, see how difficult they expected them to be, what the impact was on their mood after they completed that sort of exposure or behavioral activation, and then what their actual experience of the difficulty was when they got down and they did it. Um, we want to help them not feel so overwhelmed. When you're depressed, everything feels like a chore. We want to break this down just step by step. This is just one thing. We don't have to think about getting rid of all your depression. We're just focusing on going for a run today. That's it. This is the only thing we need to focus on in this moment. And for treatment resistant clients, we might want to take a little more structured approach and doing some like role playing to explore values and get a better understanding of that. When you are using mindfulness skills, if that's something that you're able to get to with clients, you got to be really careful that they're not using this as a way to just ruminate, that they're just mindfulness is not just being with your thoughts, it's noticing your thoughts. It's one step removed and seeing that I'm not my thoughts. We need to see shame as something that is passing. It's not who you are. This is just a feeling that you're experiencing in this moment. And if we find that they did the thing that we wanted them to do, I went for a run and it sucked. I felt terrible afterwards. Great. That's great information. Why? Was it how you were thinking about yourself? Was it something that happened along the way? Did somebody frown at you or something bad happen? So that we can understand how we can better craft behavioral activation exercises that really help the person feel good and have the goal that we want, which is to produce positive feelings. We want clients to learn how they can feel better before they can actually feel better. So a metaphor that was shared that I really liked was experiencing anxiety or depression, like a briefcase that's handcuffed to you and the key is lost. That these feelings are here. Now you could either, since this is something that you're stuck with right now, you can either spend all your time and energy trying to force this thing off you, trying to rip this locked briefcase off your hand, or you can pick it up, you can take it with you, you can say, yep, I got this with me, but I can still go about my life and do things that are important to me. Focusing on like family therapy with OCD. We've talked about this briefly. Assessment tools are going to be really important. You want to understand what are the family roles, what are the different relationships, how OCD is disrupting parenting, communication style, emotional balance. A lot of times, some family members might feel neglected or misunderstood because one person is the focus because they're problematic. And we want to understand how OCD is changing family rituals and how it's caused relationships to shift over times. You really want to help people and families understand that high levels of expressed emotions, really intense attitudes, are actually linked to worse outcomes in ERP exercises and are probably going to contribute to keeping the OCD stuck. We know that shame is a huge reason why people don't get better from OCD. And so if you're not able to complete an exposure, you weren't going to wash your hands 5 times, but then you did, and then a parent comes at you yelling, saying, hey, you're not supposed to do that. Like, that's only going to make it worse. that's just going to increase the shame. It's going to make it harder to face those exposures over time. So we don't want families to overreact to or dramatize failures to complete exposures. We want them to recognize what OCD symptoms are and be helpful. We want them to be invested in treatment because it's very difficult to treat. And the more help we can get, the better off our clients are going to be. Some strategies that families might engage in that you can help them recognize are actually well-intentioned. You're trying to help your family member, your loved one out, but often what people might do in family situations for an individual with OCD, they might try to give them advice on how to do things. That's kind of reassurance seeking. I don't have to think for myself how I can complete this. Somebody else is telling me exactly what I want to do. We're going to try to pull back on reassurance seeking. Again, you see somebody in distress, totally natural to want to provide them reassurance, help family members understand that's part of the OCD cycle. We need to break away from that. Same way with distraction. You see somebody really distressed about, oh my gosh, what if this horrible thing happens? Oh, don't think about that. Think about something else. Again, we're running away from the distress. We want to help them sit with it, how to be okay with it. So things that we can really focus on helping families do more of. We want them to have clear structure with how they're going to engage with the OCD. We want the clients we're working with to feel a sense of security and stability within their family environment. Other people in the family can model what healthy coping and problem-solving skills look like. We want to help them set realistic but kind limits as far as how they'll interact with the person's OCD. We can also use positive reinforcement. We can celebrate successes. We can use rewards and go out to dinner to celebrate accomplishments. And we want to help families accept that imperfections and mistakes are part of growth so that there aren't those big reactions when things don't go the way they had hoped or expected for the client. As far as the mindset we want family members and the clients with OCD to develop in treatment, we want them to know that OCD is not something that's logical. So if we're trying to reason our way through it, it's probably not going to work. We want to normalize for everybody in the system that fear and anxiety around the treatment is normal. That's part of it. We're facing our fears. We're facing our anxiety. And so we're going to feel those things, whether you're the person with OCD or the family member who's watching them go through it. We can try to externalize it, right? Again, we're reducing that shame and blame instead of saying, oh, you know, this is your problem. Why are you like this? This is your OCD saying this. You come up with whatever name the family and the person is comfortable using to call out their OCD. And let's focus our therapy on what's causing the most distress, not what's just the most observable behavior. So oftentimes family members might say, hey, you really got to stop the hair pulling for them. They've got a bald patch going on. Nothing wrong with being bald, by the way. They've got a bald patch. Like, that's really distressing for them. You got to stop that. But maybe that's more distressing for the family to see that. And when you talk to the client, they're like, actually, no, I'm like not eating. My contamination fears, like I feel like I can't eat foods. We need to focus on what's causing the most distress for the person. When we're working with families, we got to create a treatment plan that everybody's on board with so that treatment doesn't stagnate. If family's not involved, there might not be an ability for that individual to get better without that support and engagement from their family. We want, again, gradual re-engagement, and slowly pulling back accommodations. Things need to be predictable and routines kind of established. We want the family and our clients to work together with us to create clear collaborative goals. And when we're really working towards making change in families, we want them to focus on what you're trying to protect, not just what's not working. Oh, that didn't work. Okay, well, what are we trying to aim towards again, right? We want this person to be eating at the dinner table again. Okay, how do we work on that? And how do we get there? Not just focus on this isn't working, this isn't what I wanted. We want to use our experiences to adjust expectations and create more realistic plans that will be successful in the future. We want to support family members too that might feel so much pressure and discomfort in helping the individual with OCD face their fears. And maybe they need support. Maybe they need some adjunctive therapy or to work with somebody on that, or to have a session outside of therapy to figure out how do we get you to pull back those accommodations. And again, if they're stuck, we need to be flexible too. We need to try to shift our strategies or target different symptoms if both the family and the client aren't ready for what we've been working on. We want to stabilize the client and family. We want to separate what are real fears versus OCD-based fears, kind of thinking through things. We want to facilitate like functional family change. And you should expect resistance. These are not going to be easy things. People are going to push back. They're not going to want to do it. So we'll have to adjust our scale, our goals accordingly, and figure out what we're doing. And when it's not working, we adjust it. We'll also probably have to expand outside of just the family system, especially when we're working with children. We might have to work with schools as well. And we want those shifts, just like we were talking about with families, to be small and gradual. We want to find some kind of middle ground for families where they're not overly accommodating, but they're not too rigid in their approach either. We want to all be together in this. So the client feels supported, the family feels like they're also working or moving in the right direction. We want everybody to be on board with the change. We want our steps for change to be realistic. And let's use assessment tools to try to figure out maybe like where the easiest change is going to come from so that we can have that win to begin with. When things won't change, we have to, or the client isn't willing, no, I'm definitely not going to be doing these exposures, then we lean even more heavily into the family system and other systems surrounding the individual to figure out, okay, then how do we reduce our reinforcement of OCD? How do we pull back our accommodations? And how do we change our lives so that the person with OCD has to face these things? And this is the last section that I'm going to cover. I know I blew through all of this, so hopefully I'll have time for. Yes.
I'm wondering, and I know we could certainly keep going. If anyone, just with the last 5 minutes that we have, and I can put all these slides, of course, in as well. I just wanted to pause for a minute for questions, or if there's any specific cases that you guys have that some of this is really beneficial, but you wanted to ask Dr. Kevin an additional question. I just want to pause for a minute to allow for our end of the hour questions before Kevin keeps going. You guys are welcome to raise your hand or just speak, but if you're thinking of anybody on your caseload, Joey, please.
I'm thinking of psychoeducation on OCD for the children that are disinterested in psychoeducation. Like, what is your most brief synopsis of the neurobiology behind OCD for someone who doesn't really want to sit there and listen to it?
Yeah, I think using things like the idea that like your brain is trying to keep you safe, right? Isn't that what OCD is telling you to do? I have to do these things to be safe. I have to wash my hands 10 times or I'm going to get sick. And so helping them understand like it's just working too hard. We need to pull it back and we need to get it to like a realistic level. Another piece of psychoeducation that might be helpful is sharing like kind of like your internal brakes aren't maybe as effective as other people's, right? When you feel this need to go do this thing, you're gunning for it 100%, and it's hard for you to slow down and stop. And so letting them know that like your safety system is overactivated, we got to get it to a normal level, and we have to figure out how you can use your like internal brakes when you feel like doing something, how to not do it. Is that broken down enough?
I like it. Thank you.
Sure.
Go ahead, Michelle. Hey, Dr. Kevin, I have a question. I found it interesting what you said about depression and OCD. I have a client who has some mild depression, but he also is having really severe
panic attacks with increased frequency. And I think part of it is this is his first time coming to therapy for OCD. He's been trying to just like push it all down. And so it comes out as really significant panic attacks, like he goes to the ER. So how do you suggest like where to start? Because when he and I are problem solving together, he's like, I just need this to stop. He's like 23, 24, you know, so it feels very new, not a whole lot of like self-awareness yet. He does take Prestique, you know, but other than that, and that just started, I think, 10 days ago. I've seen him twice. So just, I thought we said about depression was helpful. So I thought you might have some advice for the panic.
Yeah, I wonder about like, you know, if I'm wondering like if this client is somebody who's really like blaming themselves, right? I need this to stop.
Yeah.
I need this to stop now. Can I build like a more compassionate viewpoint, right? Where I don't need to feel ashamed and guilty about how I'm feeling, trying to focus in on like, hey, you're here, you're taking the steps. You started medication for the first time. You just started it 10 days ago. We gotta, you know, give it some time, but try to focus in on like, how do you build yourself up? You're here right now. You're meeting with me each week or more than that. And like, what else can you be doing? And maybe even getting them to see like, right, like, you know, we do want these panic attacks to stop, but not only do you want to stop these things, what do you want to be doing with your life? Can we get into like doing some things? What's important to you? What brings you joy and pleasure? And if they're not able to do those things because of the panic attacks or OCD or depression, okay, well, how do we start getting there then? What are some steps to maybe get there? Does that sound like it could be helpful for your client?
Great. Because he has said like his girlfriend really wants to go to Europe next summer. And he's like, I know I should want to go. He's like, but I won't go. I'm terrified. So I think that would be a really great point to bring up to him.
Yeah, you're terrified now, you know, and that's okay, right? That's scary. I was terrified. I went to Europe this summer. I was terrified. I didn't know what was going on, what to expect. And that's okay. But maybe exploring values. Is this something that you want though? Do you want to be able to do these things? And then if you do really want that, if that is important to who you are, how do we start to take some steps to get there?
Okay. Awesome. Thank you so much.
Any other questions? I know we're at 10:53. Dr. Kevin, of course, is an amazing person to help you talk through cases, kind of conceptualize what to do next. I want to thank everyone for joining. Dr. Kevin, I will absolutely put your slides we'll put it in the OCD folder, everybody, for you to look at in the future. We'll stay on for a minute if anybody has any questions. Otherwise, we'll let you guys get on to your 11 o'clocks. Have a wonderful day.
Thanks, everybody.
Great job, Dr. Kevin.
Thank you.
I have a quick question. This will be super quick. Do we
Yeah.
need medication in order? I know that's best treatment. I have a client that